Very good evening to all. And thank you, Team Extempo, for giving me this opportunity to share more than 15 years of my experience with fetal MR. I have no conflict of interest to declare with respect to the presentation, and a small disclosure that prenatal sex determination in India is banned under the PCPNDT Act, except for the conditions prescribed in the Act. I would be addressing the talk in six different parts. Since its first reported use in 1983 by Smith et al., fetal MR has come a long way. However, its use in evaluation of abdomen and thorax has been reported only since 2001. Though ultrasound remains the primary modality for diagnosis of these lesions, MRI plays a very important role in characterizing these lesions, which in turn have major implications not only in prognosis and counseling, but pre and perinatal management. T2-weighted haste and a trophy or a balanced SSFP, depending on the type of machine, is used for evaluation of the anatomy. T1 wide is used for evaluation of the bowel, liver, and heterogeneous lesions. Diffusion weighted is used for evaluation of the fetal kidneys and their function and heterogeneous masses. And T2 star is used for evaluating unexplained hepatomegaly and a fetal cine for demonstration of the esophageal pouch. On a T2-weighted haste, the small bowel or the jejunal loops are seen as serpiginous intermediate signal intensity structures, which after 25 weeks become more and more hyperintense due to increased gastric emptying. The fetal colon is seen as a T2 hypointense structure, right, going up to the perineum, slightly posteriorly directed, behind the hyperintense bladder, which is anterior to the rectum. This is a coronal showing the rectum going straight up to the perineum. Kindly keep this imprint in your mind for future reference. On T1, the colon or the rectum appears as a T1 hyperintense structure behind the hypointense signal of the bladder, and the rectal cul-de-sac extends 10 millimeters below the bladder neck in a normal fetus. At 24 weeks, you start seeing the sigmoid colon, the ascending colon, and the splenic flexure with the cecum, the ascending, this was the descending colon and the splenic flexure, with the ascending and the proximal transverse colon. 25 weeks onwards, you start seeing the entire colon with the obliquely oriented ascending and the transverse colon. Fetal gallbladder is seen as a pear-shaped hyperintense structure on the inferior aspect of the liver, which after 30 weeks shows variable signal intensity varying from iso to hypo to hyperintense, and this should be kept in mind. Normal liver is seen predominantly in the right upper abdomen as an intermediate hypointensity and small part on the left side. On T2 star, the hypointensity is slightly higher as compared to T2 haste. And on T1 weighted, it is seen as an intermediate T1 hyperintensity when compared to the high signal intensity of the meconium in the bowel. Adrenals are seen as triangular caps with central hyperintensity or trifoliate structures with peripheral hyperintensity on a T2 weighted image. Fetal kidneys on T2 weighted are seen as bean-shaped structures with intermediate signal intensity and a peripheral and a central hyperintensity representing the perirenal fat and the renal pelvis respectively. Diffusion weighted demonstrates the functioning kidneys as well-lit structures against a dark background. The spleen is seen as a small bean-shaped structure in the left posterior retroperitoneum behind the stomach, as you can see in this image on a T2 haste. Having understood the normal anatomy on MRI, I will now take you to MRI in abdominal lesions, which I have divided into 4 parts. Coming to genitourinary and anorectal, there's a lot of heterogeneity in the terminologies which have been used to describe anorectal and cloacal malformations. So for the ease of understanding and to make it easier for the diagnosis, I have divided them into anorectal malformations and cloacal malformations. So anorectal malformations address the malformations due to anal stenosis, imperforate anus, or anorectal agenesis with or without associated fistulas, and they may be high or low. So a dilated cystic structure anterior to the sacrum with or without enteroliths and an absent or an abnormal target sign will tell that this is a likely anorectal malformation from ultrasound itself. An MRI would confirm the diagnosis by identifying it as a dilated rectum and characterizes the signal intensity of the bowel and the bladder to demonstrate associated fistulas. Coming to cloacal malformations, they are either true cloacal malformations, which have no perineal opening or single perineal opening, and urogenital sinus malformations, which have two perineal openings. And depending upon the location of these openings and the proximity of these openings on the perineum, they are further subdivided into persistent and posterior cloaca, or these three variants of urogenital sinus. Now, whenever a complex cystic structure is seen on ultrasound in the pelvis, the first step we do is evaluate the fetal perineum either on ultrasound or MRI and look for the number of openings. Then we evaluate the bowel parameters on MRI, starting with the level of meconium signal, which is whether we look for its presence either above, at, or below the level. 10 millimeter below the bladder neck is a normal level of the rectal cul-de-sac. We look for the bowel caliber, whether it's normal or dilated. We look for the bladder bowel signal on T1 and T2. We look for presence of ascites and relationship of the cyst to the rectum, the signal intensity and the bladder, the signal intensity of the cyst, and whether the cyst is septated or not. The next, we evaluate the urinary system and look for associated malformations, paying special attention to the adrenals, the genitals for ambiguity, and the anterior abdominal wall in addition to spine. Now, the findings which are common to both cloacal and urogenital malformations are a hydrometrocolpos, which is identified as a dilated retort-shaped structure between the bladder anteriorly and the rectum posteriorly, with or without duplication abnormalities. The signal intensity in this structure is either similar to bladder or intermediate if it is urine mixed with mucus, or urine mixed with mucus and meconium, depending on whether it is a cloacal or a urogenital malformation. Marked ascites is a common feature, and variable degrees of hydrouretronephrosis also is seen in both the condition. What differentiates the two is that in true cloacal malformation, there will be no or single perineal orifice. The dilated colon will show a decreased signal intensity, and it will be located at or above the bladder neck or slightly below the bladder neck, depending upon the length of the common channel. In a urogenital sinus malformation, there will be always two perineal openings. Bowel caliber will be normal, signal intensity of the colon and the bladder will be normal, and you will see that the structure, the colon, extends right up to the perineum and opens at the anus with a normal target sign which is seen. Now, having understood this approach, we will now apply it to a fetus who was seen by us at 32 weeks. As you can see, there are multiple cystic structures in the pelvis with the bladder identified by the iliac vessels, and there is associated ascites. So as I told you, the first step that we do in evaluation is look for the perineal opening. So here the target sign is very well seen. The two perineal openings are seen with ascites and multicystic structures. So this tells me that this is likely to be a urogenital sinus malformation. On MRI, a structure is seen interposed between the rectum and the bladder. On coronal, you can very well appreciate that. This is anteriorly placed bladder with a retort-shaped structure with the two cornua of the uterus, likely a didelphic uterus, with the normal signal intensity of the rectum, which instead of going straight into the perineum is seen to turn anteriorly, which tells me that this is a cloacal variant of urogenital sinus with ambiguous genitalia. You have ascites and bilateral renal pelvic dilatation. So because of the time constraint, I would not be able to cover all the entire spectrum of these malformations. But if you follow this approach, you can invariably reach to a conclusion with confidence. A double bubble sign on ultrasound tells me that this is a duodenal obstruction. MRI tells me that this is an annular pancreas with a clear sign as a cause of the duodenal obstruction. Whenever a bowel dilatation is seen on ultrasound, MRI plays an important role in characterizing the cause of dilatation and localizing the level of obstruction with an accuracy of 93%. So once a dilatation is seen on ultrasound, on MRI, we look for the situs, we look for the location of the bowel loops, we look for location and measurement of the post-obstruction segment of the bowel loop, and look for the signal intensity to get to the differential diagnosis and the cause of the dilatation. So once we then apply this knowledge in identifying the cause. So if it is a normal situs or a situs inversus, then the first thing we look for is the stomach bubble. And below the stomach bubble, if we see small bowel loops, which are normally placed, it rules out the midgut malrotation. If you don't see small bowel loops below the stomach, then you have to suspect a midgut malrotation and you go back to ultrasound, switch on the color, look for the superior mesenteric vein orientation to reinforce the diagnosis of a midgut malrotation. Now, level of obstruction, if the colon is normal size with the proximal bowel dilatation, it is a jejunal stenosis or atresia. If you see normal or slightly dilated fluid-filled loops in the left abdomen up to the dilatation, then it's a distal ileal stenosis or atresia. The T1, T2 signals cannot be relied upon to determine the level of obstruction. MRI also characterizes whether it is a stenosis or an atresia. So if it is a bowel stenosis, the post-obstruction loops will have a normal caliber. If it is an atresia, the post-atretic bowel will have a small caliber. And if it is multiple atresias, you will not see any bowel beyond the level of atresia. And this is determined by measuring the meconium signal intensities, and we have normograms available for the same. Now, use of signal intensities for determining the cause of dilatation. So if there is an intermediate signal intensity seen in the dilated bowel loops, it is either a meconium ileus, a Hirschsprung, or a volvulus. Now, if it is an intermediate signal with a microcolon, dilated loops in the right abdomen with meconium balls, it tells us that it is a meconium ileus, either due to cystic fibrosis or infective etiology, depending on presence or absence of the gallbladder. If it is there is no microcolon, but the rectum is either normal or dilated with a normal target sign, it points to a Hirschsprung disease. And if there is an associated stomach dilatation, polyhydramnios, whirlpool sign, or a coffee bean sign with an SMA rotation, it tells me that this is a volvulus. In ileal stenosis or atresia, the signal intensity on T1 and T2 will be normal. And microcolon may or may not be there, but it is only and only from the signal intensities that you say that it is a ileal stenosis and neither of these conditions. So having understood this, we now go to a case, 32 weeks and 4 days fetus with a large heterogeneous cystic structure seen in the occupying almost the lower abdomen. And there is a daughter cyst-like structure which is seen within the cyst. The small bowel loops are dilated. And here you're seeing even the colon, which looks pretty much normal. So our differentials were either a meconium pseudocyst or a large hemorrhagic ovarian cyst. So on MRI, we could see the stomach and the normally placed small bowel loops. There were dilated bowel loops with intermediate signal intensity on a T2 weighted haste and intermediate T1 hyperintensity on a T1 hyperintensity of the bowel loop was seen. Then intermediate because it is lower as compared to this hyperintensity, which is normally expected. So this was an associated meconium pseudocyst. So this was a meconium ileus, because there was an associated microcolon which was demonstrated. And presence of gallbladder rules out cystic fibrosis as a cause. So because of time constraint, again here I would not be going through the entire spectrum of bowel dilatation abnormalities on MRI, but again, this approach can give you the diagnosis with pretty much confidence. MRI in gastroschisis, the very next talk is going to cover this in detail. So just a brief about it, that MRI is used for characterization of complex gastroschisis. And recently, Daniela Pryor and her group have shown the use of volume ratio between the event-rated organ volume and intra-abdominal volume for predicting the treatment modality using a SiloBac treatment with 90% accuracy. And this is how the volume is measured using an ITK SNAP software. Fetal urinary tract abnormalities. Diffusion weighted can be used for identifying an ectopic kidney anywhere in the abdomen or pelvis if it is not seen in its normal location. And even the renal function can be assessed using diffusion weighted when you see a small dysplastic kidney on ultrasound. MRI plays an important role in differentiating functional from obstructive etiology in megacystis, characterizing differentiating a megaureter from other complex pelvic structures and diagnosis of a prune belly syndrome. So this was a 25-week fetus with dilated bladder and a dilated posterior urethra with an abnormal opening of the ureter in the bladder neck, as seen on single-shot urography. Anterior abdominal wall is appearing lax with undescended testes in the scrotum, and this tells me that this is a prune belly syndrome. And in absence of these two findings, it would be a posterior urethral valve. Another case, 26-weeker bilateral renal pelvis dilatation and a cystic structure seen below the bladder with a dilated renal pelvis and the tubular structure leading up to the bladder, and a 3D showing a megaureter going into the bladder with the uretrocele. This was a diagnosis made on ultrasound. MRI confirmed the diagnosis and showed this ectopic urethral insertion, but we could not make out the bowel signal on T2, and T1 weighted showed us a very normal looking bowel signal, ruling out a microcolon which is associated with megacystis microcolon intestinal hyperperistalsis syndrome. So this is how MRI can be used in characterizing a megacystis. Lesions of the adrenal region. This is a list of the lesions. I would be taking only a few common ones because of time constraint. So an echogenic lesion in the region of the adrenals, no blood supply, so sequestration is ruled out, and bilateral renal arteries are seen. The lesion is seen extending into the thorax with small cysts and peripheral, very minimal blood flow. So this is typical of adrenal neuroblastoma, which was confirmed on an MRI. You can see the extension of the lesion into the thorax, and what MRI, the other information that MRI gave us was that there was no infiltration of the liver, and so this was a L2 stage of neuroblastoma. The normal kidneys were seen on diffusion weighted, and there was diffusion restriction which was seen in the lesion, which reinforces the finding of a neuroblastoma. A 25-week fetus with a cyst in close association with the small dysplastic looking kidney. This was a urinoma which was confirmed on MRI, and the normal adrenals were seen above the urinoma. And diffusion weighted can be used to assess the function of the kidneys associated with the urinoma. Unexplained hepatomegaly, T2 star can be used to diagnose fetal hemochromatosis, and which is seen as a dark T2 hypointense structure as compared to the maternal or fetal fat. And this helps in starting intravenous immunoglobulins in the prenatal period, preventing postnatal consequences. MR in fetal tumors and cysts, it helps not only in getting closer to the organ of origin, but also helps in identifying the extent of the lesion, contents, and distorted anatomy. So there is a huge list, but I would only be taking you through a couple of them. A large cyst in the abdomen, which was seen pretty much occupying the lower abdomen below the liver. It was found to be anteriorly located and pushing the liver to the side. It was arising from the liver, and there was no connection with the biliary system, and so this was diagnosed as a simple hepatic cyst. If it is a choledochal cyst, as you can see here, it will have connection with the biliary tree as seen on ultrasound and MRI. Another cystic lesion in the pelvis, as you can see here, this cyst is anterior to the sacrum and posterior to the rectum, which tells us that this is a sacrococcygeal teratoma, more in the pelvis than external. And this is a myelograph showing the lesion within the pelvis, and it is posterior to the meconium signal. This is a postnatal image showing the sacrococcygeal teratoma. And diffusion restriction tells that this confirms that this is a sacrococcygeal teratoma versus a cystic lymphangioma, which has no diffusion restriction. And it coming to the fetal thorax, this is the normal lung, as you can see on a T2 weighted haste with the intermediate hyperintensity and the tracheobronchial tree, which is also well depicted. And we always evaluate the fetal hypopharynx whenever we are looking at the thorax or we suspect an esophageal abnormality. Echogenic lesions on ultrasound, congenital cystic lesions or hybrid lesions are well characterized by fetal MRI. This was an echogenic lung with a flattened diaphragm and a feeder vessel. So a diagnosis of a congenital lobar overinflation with associated bronchial pulmonary sequestration was suspected on ultrasound. MRI, however, showed that there was a proximal bronchocele suggestive of a bronchial atresia. And because of the mediastinal shift, these lesions need to be monitored for fetal height drops. On follow-up, this lesion was shown to regress. However, patient did not agree for a follow-up MRI. And though this was apparently regressed lesion, there was a underlying microcystic CCAM, which would change the diagnosis, the postnatal management if it was missed, which could have easily been picked up on a prenatal MRI. MRI in CDH, it is very important in identifying prenatal predictors of perinatal mortality and morbidity and neonatal care strategies. There is a list of parameters which are evaluated in a CDH on MRI, and I would take you through a case. This was a left-sided CTH with the heart being pushed to the right, the normal contralateral lung. And though we thought that this was a normal contralateral lung, it turned out to be a herniated liver with a very small ipsilateral lung seen. And this is a herniated liver with the herniated bowel, which was seen in this 27-weeker. And next, we evaluate the contralateral lung volume, ipsilateral lung volume to get a total lung volume and observe to expected percentage total lung volume. We get the predicted percentage fetal lung volume from the thoracic and mediastinal volume. And then we get percentage liver herniation from the total and the intrathoracic liver volume, and liver to thoracic volume ratio, which is derived from the total thoracic to intrathoracic liver, and a defect to diaphragm ratio. So we combine all these parameters, and these parameters show that the likelihood of survival in this fetus was good with the need for patch repair. We also evaluate the risk of primary pulmonary hypertension, which was low in this case, and the need for ECMO was predicted to be low. The risk of chronic lung disease was predicted to be low. The CMA was normal. The baby was operated on day 2 and is currently doing well at the age of 8 years. Unilateral hydrothorax in a 37-weeker, you see that this is a normal intermediate hyperintensity of the lung, which is to be expected, but instead we see a heterogeneous signal with linear hyperintensities running from the hilum to the periphery. And this is a typical nutmeg lung with unilateral hydrothorax, and a finding very peculiar to congenital pulmonary lymphangiectasia. In high airway obstruction, MRI characterizes the level of obstruction and guides in decision between fetal versus neonatal interventions with exit procedure. Like abdominal cystic lesions, MRI also helps in characterizing cystic lesions of the thorax. And this is a fetal cine demonstrating the esophagus on fetal swallowing. With this can be used to identify esophageal pouch in cases of suspected esophageal atresia. This is a sternal cleft which was seen in a fetus with faces. So to end, it is about time that we embrace the roles of both ultrasound and MRI in characterizing the lesions and thereby redefining the imaging landscape, doing justice not only to the fetus but to the family who benefits at large. Thank you very much for a patient hearing.